Good evening, everyone, and thank you for joining us from shots to surgery, finding the right fit for your weight loss goals. My name is Cindy Leonard, Business Development Manager at St. Alexis with Ascension, Illinois. It's a privilege to bring conversations like this to our community. We know that weight loss is a very personal journey, and tonight is about helping you understand all your options so that you can make informed decisions that feel right for you. Before we turn things over to Dr. Gusky and Dr. Kane, I would like to briefly review a few items. This webinar is being recorded. By participating, you consent to the recording and its potential use for replay, promotional, and educational purposes. If you choose to ask questions or make comments, your name and likeness may be included in the recording. The recording may be shared on our website, social media channels, emails, communications, or other marketing materials. Next, I would like to review a few housekeeping items. This webinar will last approximately 20 minutes with 10 minutes for Q&A. Use the Q&A function to submit questions at any time. Note that in some cases, the chat function can be visibly for all participants. Questions will be addressed at the end of the presentation, so please be concise and respectful when asking questions. If you experience technical issues, try refreshing and browser for reconnecting. And now it is my pleasure to introduce our speakers, Dr. Paul Gusky and Dr. James Kane, board certified general and bariatric surgeons who have cared for patients in our community at Alexian Brothers in Elk Grove and St. Alexis and Hoffman Estates for over 30 years. They are deeply committed to education, safety, and helping each patient find the most effective path towards their health goals. Please join me in welcoming Dr. Gusky and Dr. Kane.
Good evening. How are you? My name's Dr. James Kane, and Paul and I are here today to talk about just a short synopsis on the compendium of treatment that's available for you for obesity nowadays. What's hit the market in the last 5 years, the GLP-1 medications, which are fantastic and are very effective, play a role in a whole compendium of what it takes to treat obesity nowadays. So, well, I'll talk a little bit about a short synopsis on why we even care about obesity. What's the big deal? Dr. Gusky will talk to you a little bit more about the GLP-1 medications that are available and how they're effective. I'll then flip back and talk shortly about the surgical procedures and in combination therapy with GLP-1s, and then we'll open it up for some questions and answers. We'll try to make it fairly quick. So, I hope in 30 minutes we have you guys all back in your private lives. But why are we here? Well, it's not just a cosmetic issue. It's not about, hey, you eat too much and you don't have any self-control. There's a huge genetic component. Actually, the majority of obesity really is driven by genetics. We all know that. We all have family members. We all have a distant family where we're all built so differently. I mean, environmental factors play a role also, as you can see up here in the slide here. And hopefully my annotation is on here, mouse. But genetics plays a huge role. So why do we even care about it? Well, it has a huge impact on society, economically, people's productivity, their psychological well-being, their health and longevity. I was listening to a podcast that had Dr. Oz on it a couple months ago, and the huge impact on an individual living one more year of life, what impact it has on the productivity to society was staggering to me. So it's not just about that you want to look better. It is a lot about how you feel and about your productivity. And it's a progressive disease. It requires lifelong management. It's not just, I'm going to take a GLP-1 or I'm going to have surgery and that's it. It's all you have to do. It's a disease that has to be treated sort of in the long term. Why do we care about it? Because for physicians, it drives almost every disease state that we care for. The hospital is full of patients with all the different types of diseases that you see up there, all the different types of conditions. But one of the major issues is obesity is behind so much of it in our hospitals. And obesity also hinders and it complicates all the care that we deliver. It makes it more difficult to recover from surgery, makes it more difficult for you to recover from infectious disease issues, more difficult to control your diabetes, everything, heart attacks after surgery, everything that we do is driven by it. Treatments for cancer, everything. So it is fairly prevalent. In 2020, you can see that almost 42 million people, 100 million people are obese, and that's a BMI of over 35. When you jump to severe obesity, which is a BMI over 40, it's 10 million people in our society. This is a graph of the United States, of course, from 2011. This came from the Centers for Disease Control. All the states that are in green and yellow are areas where you have a low prevalence of obesity. And watch how it jumps in 12 years. All the dark states, all the orange states, red states, the percent of obesity just exploded, even in those 12 years. So it's a big issue. How do we treat obesity? As I said, it's not just one thing. Dr. Gusky is going to go over the pharmacokinetics, which is very important and really has had a huge impact. But it's everything from, if you can see my cursor, behavior modification, like starting to exercise, yoga, watching what you eat, having just better habits during your lifetime, up to things like, all the nutritional interventions such as Weight Watchers and the different types of different types of protein shakes that you can get, to the therapies which are driven nowadays by GLP-1s. And then there's endoscopic and procedural therapy of surgery and endoscopic procedures, which ultimately end up having the greatest durability in the long run. But again, they don't work alone. These things work nowadays with medications, and surgery are the best combination for certain criteria of patients. So I'm going to turn it over to Dr. Gusky now for his portion.
Well, thanks. I'm going to try not to bore you too much. I appreciate Cindy and Kristen helping us put this together and helping us realize we've been doing this for 30 years, which is quite a long time. Going back 30 years, this graph did not exist. We had basically gastric bypass, and there were a couple of medications, but in the last 30 years, the number of choices that are available for patients has absolutely exploded. And initially, when we looked at pharmacotherapy, I'm going to concentrate more on the medication therapy. We really had just a couple of different drugs that were available. And when you look at what the medical therapy described as success, was anywhere between 3 and 5% excess body weight loss. So not very much. Talking about maybe 7 to 8 pounds, 9 pounds was considered a successful weight loss medication. And in the last 4 years to 5 years, we have now seen several different medications come online, namely the ones everyone knows about, the semaglutide, which is the Wegovy, and the tirzepatide, which is the Zepbound. But prior to that, we had the Saxenda, and we've had Victoza, several different medications, which gives a little bit of weight loss. But when they found these newer variations of these medications that had a longer half-life, the amount of weight loss that we're able to achieve increased dramatically, more than double. So you're seeing weight loss of 16% excess body weight loss and 20% excess body weight loss, which translates to 30 to 40 pounds. So we're seeing much better options. The GLPs, it's simple to say, well, they just help us lose weight, but it's helpful to understand why and what other positive things that they do. Initially, when they first brought these medications to market, we didn't have a lot of information, and we know that patients were losing weight. As they study them more, we now see that, again, these two medications do different things, and I'll delve into it in a minute. They function on different receptors in our body, and these different receptors are actually receptors for naturally occurring hormones that our body makes. These are actually hormones that we're able to produce, that our body makes, and we increase the amount that we give, and there's a little bit longer half-life. But what they mainly work on is the GLP receptor, which is called glucagon-like peptide. And that receptor is kind of throughout the body, primarily in the gut, in the intestine, in the stomach, in the brain, and in the heart and cardiovascular system. We also see some effect in pancreas as well. We also discovered, as they branched from Wegovy to tirzepatide, there's a different receptor called GIP, which also affects liver. It affects how fast your body burns fat in the muscle and how fast your body burns fat at getting rid of your fat. So the benefits have now increased dramatically from just weight loss to other medical indications, including things like sleep apnea, heart disease, liver disease, kidney disease, and we're seeing a much more broad-based effect that's really helping patients dramatically. The first one that really came to market that had widespread success was Wegovy, and this was Ozempic back in the day. And Ozempic was primarily a diabetic medication, and it's actually the same exact medication, it just got a different name and a different indication. And Wegovy is specific to the GLP-1 receptor, so it's just that one receptor that is primarily in the gut, the brain, and the heart. So it is a naturally occurring hormone, as I stated. It does increase the amount of insulin, so it decreases your blood sugar, and it decreases glucagon. And glucagon is the actual hormone that makes your body's blood sugar go up. So both of these effects are a lower blood sugar level. It also works on your brain, and there's a part of our brain called the hypothalamus that does suppress our appetite and makes us feel full. So it does not, it's not just decreasing your insulin or increasing insulin and decreasing glucagon. It also helps suppress your appetite. It has some gut functions, and it makes your stomach empty slower. So the food that you eat stays in your stomach for a longer period of time and makes you feel full. And by doing that, it reduces glucose production in the liver. So all these things decrease the blood glucose and increase your satiety and make you feel full. The net result that we're seeing is a weight loss between 5 and 15%. And again, everyone's an individual. There are some people that lose 0, and there are people that lose more than 15%. But when you march it out with large series of patients, the average number we're seeing is right around 15% of your excess body weight. So other indications that have now come out since this medication has been on the market is the increased protection from cardiovascular events. We're seeing this medication improve cardiovascular health and decrease the risk of severe cardiovascular events, which has really been very helpful for patients, and also reduce the risk of fatty liver disease. We used to call it NASH, now they call it MASH, which is metabolic steatohepatitis, which is fatty deposition in the liver. So we see less fat deposition in your liver, which increases your liver health. So that's Wegovy, which has been the first to market. And then a few years later, tirzepatide, which is Zepbound, which was the old diabetic drug called Mounjaro, that came to market. And that is a similar drug in that it targets the GLP receptor, but it also targets a second receptor called GIP. And that has a little bit more broad-based effect. And it does a lot of the same things, increases insulin, decreases glucagon, but does so in a greater manner than semaglutide because of the dual receptor function. It works on your hypothalamus in your brain to decrease hunger, and it delays gastric emptying. It increases your fat burning to a much greater degree, and that's why we're seeing an increased weight loss. We're seeing the fat burning in the muscle as well as in the fat in our body at a much greater rate, and that has translated to a much greater weight loss of up to 21% in patients. The other thing, because it's a more of a selective receptor, we see fewer GI side effects like constipation and diarrhea. So we're seeing much better compliance with this medication. What we have seen, and to look at this in the last couple of years, 12% of U.S. adults had tried one of these medications. So 280 million people, 12%. You're talking about 30 plus million people have tried these medications. I'm sure everybody knows somebody who has tried these medications. About 86% of these patients, however, will stop taking them in the first 2 years for a myriad of reasons: insurance coverage, financial reasons, side effects. They reach a plateau and stop losing weight. And the bad thing about these medications is once you stop them after that 1 to 2 year stint, your weight comes back on. In fact, about 66% of your weight comes on within the first 6 months and about 75% at the first year. So we're seeing a much higher rate of weight regain. So it really emphasizes the need to continue with this therapy for the long haul. This isn't a short-term fix where you can do it for 6 months, feel better, and stop. When do we use these? Who are good patients? Who are good candidates for these medications? Well, the main indication is going to be overweight or obesity. So historically, we defined obesity as a body mass index of 35 with medical problems or 40 without medical problems. We've lowered the bar with these medications because there's fewer risks associated with them. Our indications now are a body mass index over 30 with no medical problems, or a body mass index of 27 or greater with medical problems like diabetes, heart disease, kidney disease, sleep apnea, or fatty liver disease. Other indications are when patients just simply don't want surgery or don't meet criteria for surgery, so they prefer more of a non-surgical approach. We see it a lot in our patients who've had weight loss surgery in the past, and we see really good weight loss after weight loss surgery. Some of our patients will regain 15, 20, 30 pounds after their weight loss operation, and these medications help get that weight back off again. We're seeing as much as 30 to 40 pounds of weight loss in our weight loss surgery patients. Not many contraindications, so most patients can take these medications. Probably the only two real big contraindications that are out there are a history of medullary thyroid cancer in yourself or your family, or a known history of allergy to the medications that I listed above. Summary, we'll sum it up. They looked at these two studies were done. The first one was a STEP trial, and these were 2,500 plus patients. Mean body mass index was 38, and we saw 15% body weight loss at 16 months. The SURMONT trial was done with tirzepatide or Zepbound, and again, similar patient selection, but we saw a 21% body weight loss at 17 months. So a little better weight loss result with the tirzepatide versus the Wegovy. Other findings that they were able to glean from these studies, we saw a greater percent weight loss in lower BMI patients. So the patients with higher BMIs in the 40 to 50 range did not lose as much weight as patients in the lower BMI range. As I mentioned earlier, about 2/3 of your weight comes back on within 6 months to a year if you stop the medication. They have been able to identify this patient group at 27 to 35 body mass index as the patients that get the most success, and that's where we target our therapy at. Can't reiterate it enough. You have to stay on this medication indefinitely or your weight will come back on. So these therapies are really for patients who aren't quite ready to entertain surgery, don't meet criteria for surgery, or are kind of looking for a stepping stone to begin their weight loss journey. So that's kind of the medications in a nutshell. And I'll throw it back over to Dr. Kane so he can start talking about other options.
Yeah. So as Dr. Gusky was talking about, when to even consider bariatric surgery, I mean, it's a whole litany of reasons. It's a personal discussion with your physician. Some people would just prefer a more permanent fix and not have to take shots on a continual basis. That about 70% of people regain all their weight coming off medication. So when you commit to the medication, you really gotta commit to the medication. And if you have a BMI of 40 or above, you're really swimming upstream to try to have the medications as the sole reason to lose weight. You really should consider a combination therapy, just like you have a heart attack or a heart disease. It's combination. It's cardiac bypass. It's a stent placement, hypertension medications. It's lowering your cholesterol. It's a whole host of things that make your heart health healthy. It's the same with obesity. You've got to consider it's not just a one and done thing. There's multiple things that you may have to do because it's a progressive, long lasting disease. Some people are just unwilling to take shots, and you have a BMI over 35 with a comorbidity, which means another medical problem, you're a candidate for surgery. If you have a BMI over 40, anybody, almost all insurance policies will cover bariatric surgery. Bariatric surgery is covered more by a greater percentage of insurance companies than the GLP-1s are at this point. But I do feel that the federal government right now is pushing to make the GLP-1s more available on a widespread basis for much lower costs so that everyone, because obesity is such a big deal in westernized societies, that they're trying to make it so that everybody can get their hands on this type of thing. The Again, matching the patient to the treatment, a lot of different issues regarding that. A lot of it is weight related. What's your BMI? What's your gender? What's your eating pattern? A whole host of things. Have you tried different weight loss programs before? Were you, did the medications fail on you? Are you scared to take shots? A whole host of things that go into why you would consider going through surgery. It is the most effective. It is the most durable. Keep that in mind. It's the most durable procedure out there, especially if you have a BMI over 30. Basically, when you hear stories that, oh, they had bariatric surgery and they failed, that's one of the rarities. People almost always maintain the majority of the weight that they've lost after bariatric surgery. What does surgery do? It affects everything. All these medical issues end up being affected by massive loss of weight. It's the most proven effective tool for weight loss over the long term. Surgery, again, this is just a tool. This is not a cure. It's not a one and done thing. You may have some weight regain issues, as Dr. Gusky discussed. Nowadays, what's the most important thing is we've got other tools in the toolbox, other arrows in the quiver, if you will, to help you stay successful at your weight loss. Remember, it's a chronic disease, but the major studies do show quality of life improvement significantly. Everybody that goes through bariatric surgery, in general, on the national scales for quality of life, 95% will say their life is better. And what's amazing is your risk of death in 5 years is cut by 90% after going through bariatric surgery. A lot of people don't understand that. They think, oh, I don't want to do surgery because I don't want to die from it. It's the exact opposite. The likelihood of you being alive 5 years from now after bariatric surgery is 90% higher. So it's a big issue. What are the options that we have now? Really, three main options that are done mostly in the United States. The sleeve gastrectomy on the left, is probably the majority of the procedures that are done around the country. It's not necessarily the one that gives you the greatest weight loss or has the greatest durability, but it is the most common. Why is it the most common? Because technically it is easier. So for a lot of surgeons, a lot of young surgeons out there, they will focus on the procedure that they learn that's easy to do. These are all done robotically and are very safe. These are the risk of going through one of these bariatric surgeries is no different than getting your tonsils removed. It's about 0.1% risk of dying from it. So it's a very, very rare event, and much higher dying from obesity than dying from a bariatric surgery. But that's why sleeve gastrectomy tends to be the most commonly used one. The gastric bypass, which is in the middle, adds some reduced absorption because it bypasses some of your intestinal tract, which adds a little extra weight loss. And then the single anastomosis duodenal bypass, otherwise called the duodenal switch, we reserve that for people that are very high BMI. So it's the most effective, gets you the most weight loss. As we go through it individually, why does the sleeve gastrectomy work? Well, we remove, I don't know if you can see my cursor over here, hopefully. We remove about 85% of your stomach is removed. And the area that is removed is responsible for the production of one of the hormones called ghrelin. And ghrelin helps reduce, by removing that area and reducing the ghrelin, it helps remove some of your satiety center. In general, you're not as hungry after these operations. And also, you have a very reduced capacity for food through that middle area. And after 1 year, most people will lose about 25% of their excess weight. So let's say you're 300 pounds, you're going to lose 75%, almost for sure. You're going to lose 75 pounds of excess weight starting at 300 pounds. And in the long run, at 3 years, you're still going to be darn close to that 75 pounds. Now, you may gain a little bit of weight, and generally what we'll do, Dr. Gusky will throw one of the GLP-1s at you to help reduce your appetite some more and help you maintain that long-term weight loss. Jumping to the gastric bypass, similar issues. It helps reduce that famous hormone ghrelin, but it also creates some reduced absorption of bypassing some of your intestinal tract. So that's why you tend to have greater weight loss with it, and it's more durable. In other words, it's harder to regain weight with this surgery. So this works better on certain people. In general, you'll have about 30% of your excess weight. Again, 300, let's say you're a 300-pound person. That means you're going to lose 100 pounds. Almost everybody will. Some people will lose 50, some people lose 75. But you're going to lose about 100 pounds. And even 3 years later, you're going to be darn close to that. So it's going to be less likely you're going to gain weight with that. And then the last one, again, that's used for very high BMI people who have very bad genetics, at times very bad behavior. A lot of times bad behavior is related to the genetics. You have difficulty controlling sweets, difficulty controlling your appetite. A lot of that's just genetics. What this does, it's basically a sleeve gastrectomy, which gets rid of the ghrelin, reduces the volume of food you can eat, but it bypasses a significant amount of your intestinal tract so that you do have significantly reduced absorption of calories. And it makes it very difficult to regain weight. With this operation, let's say you're 300 pounds, you're going to lose 150 pounds and most likely keep the majority of it off. So, there are you have to be diligent about your vitamins when you have this operation because you can have some reduced vitamin absorption. But nowadays, with the modern vitamins that are given bariatric patients, we rarely see any type of vitamin deficiencies with them. So this is a slide that shows you the volume of the operations that are done basically in the United States. As you see, the blue line is sleeve gastrectomy. And in 2012, it did pass the gastric bypass. So you can see on volume of procedures done, sleeve gastrectomy is higher. Again, I don't agree that that's necessarily the way it should be. At times, I think it's overutilized. And people, the wrong patients are getting the sleeve gastrectomy. They have weight regain and basically say, hey, bariatric surgery doesn't work. That's not true. What that means to me is you got the wrong operation. Person you went to did not go through your issues well enough with you and target the right operation for you. Gastric bypass is the next one. Revisional surgery, which can be a lot of these patients up in the sleeve category, need to be converted. The gastric bypasses or duodenal switches are down a little bit farther. But the safety risk is huge. As you look at this, it's about 0.1%. It's like having, it's more dangerous to get your gallbladder out basically nowadays because of how we prepare patients and how we take care of them. From an economic standpoint, third-party payers, or let's say if you have Blue Cross, they're going to get paid back in 2 or 4 years. Yes, it costs something to go through this, but overall it ends up being less expensive than the GLP-1 therapy, which is a lifelong treatment. In 2 to 4 years, they're going to make their money back. And the healthcare costs are reduced significantly, 30% reduced healthcare costs for people within a 5-year time period. So they do have a big impact. The next, I have a video of one of these operations being done robotically, just so you have an idea of what robotics really is. So if you're a little squeamish about this, now you're probably not squeamish if you watch The Pit on HBO or whatever, about the nowadays, probably nobody's squeamish anymore. But if you are, you may want to turn away. Hopefully this thing will work.
And the phone.
I'm turning off the video or the volume on it. This sort of shows you, the doctor, we're sitting, it's not, when we say you're seeing robotic surgery, this is not Optimus robot from Tesla, who's automatic, independent, autonomous, doing it on his own. The doctor is sitting in a console away from the patient once he puts all the access tubes into the abdomen, and he sits then at a console and controls these levers or these arms while our assistant sit at the bedside and place what instruments that you need during the procedure. As you can see, I'll even speed it along. What is done with these instruments? We're able to do all this by sitting about 15, 20 feet away from the patient. So it is an absolute game changer on precision. And that's one of the reasons why the procedures are so safe nowadays. So I thought I would just leave this up, let you sort of see what's done with these instruments, but we can then turn to sort of question, and attempted answers, if you will, which could be directed by probably Cindy or Kristen will help direct it. If you have questions, you can go on. I have no idea how to do it, guys, but you go on there and you can raise your hand and take care of it. So.
Perfect. Thank you so much, Dr. Kane, Dr. Gusky, for your wonderful presentation. We do have one question at this point, but I encourage you all to use the Q&A function, as Dr. Kane said. Cindy mentioned at the beginning of the presentation, use the Q&A function. Only us as panelists and presenters will have access into the Q&A. So if you're worried about your I'm not going to even say it correctly. If you're worried about disclosing your name or anything like that, you can certainly do that. The first question is there a BMI that is too high for surgery consideration? In other words, is there a weight threshold that you have to get below in order to be considered for surgery?
I can go through that a little bit regarding the surgery thing, and I'll have Dr. Gusky can chime in also. No, there really isn't. Some people can be 700 pounds. It's where they distribute their fat is the most important thing, and how that obesity has affected them. Now, is it possible that you're 700 pounds and you've had 2 heart attacks and you have a massive liver, because most of your obesity is intra-abdominal, which is the most dangerous obesity? We may have to do things to try to bring your weight down with the GLP-1s and with diet, not diet programs, but the GLP-1 programs to try to get your weight down to a place that we feel is safer. But there are people that have extremely high BMIs and which would be candidates for the duodenal switch, the one I talked about. But the duodenal switch may need to be done in a 2-stage fashion. And that's the sleeve gastrectomy is done first. That's the first stage of the duodenal switch. And we would wait about a year to have you lose enough weight that makes it safe to do the bypass portion of it. But you would be a candidate. You would not be excluded, just based on your weight. It would be more your ability to get through an operation and what we would have to do to make it safe for you to get through the operation.
Perfect. Thank you very much. We have one more question. Is there a significant difference between men and women for either the surgeries or medications for weight loss?
No, not really. Our main decision making for surgeries or for medical therapy has more to do with your medical problems, your habits, your behaviors, than sex. So, men, women, we know that if certain patients have diabetes, they're more of a candidate for gastric bypass. If their BMI is a certain number, they're more of a candidate for sleeve, bypass, or switch, or perhaps the medical therapies. So we try to tailor your therapy based on your medical needs. There isn't a real difference. There's really never been any difference delineated in any studies based on sex.
Perfect. Thank you. One additional question, and I think this is correct. How would you help decide which program is best? What would you help evaluate, and what would you determine to be the next steps?
Well, I think a lot goes into that. The first is to have have patients do research. There's a lot of research online, and again, you have to be a little careful with what not everything on the internet is true. But and then come in and we can talk. We're not just because we're surgeons doesn't mean we always force surgery. We want to do what's best for you. And like I said,
We use a lot of medication.
yeah, I think sitting down and talking with you and looking at your medical problems, looking at your surgical risk, we may say, you know what? Hey, let's try the medications first and see if we can decrease your surgical risk. And who knows, if you lose enough weight, we don't need surgery. There are certain patients that we just simply know medication is not going to work, right? So if you have a body mass index of 45 to 55, you're probably not going to get where you want to be with medication. You might lose 20 or 30 pounds, which is a great start, but it's not where you need to be at. Our goal is not some number on the scale. Our goal is to have you off your medications and have you be healthy. And that should be the underlying theme. We want you, what's going to make you live longer is getting you off your medications and being healthier.
Perfect. All right. One additional question just came in. Why is the return of weight so common after discontinuation of GLPs?
Well, it's if you imagine one of the operations that we do and their durability, can you imagine what happens if we took a gastric bypass and reversed it, which can be done. We occasionally will reverse a gastric bypass. What happens? You regain all your weight. So similar to a GLP-1, you stop that, you're getting rid of the mechanism that help you lose weight. You're getting rid of its effect on your satiety center, which is your appetite center, and what it does to your insulin, what it does to your fat deposition. You're sort of eliminating that. And so your genetics are going to fall back in line. Now, that's not universal. Some people, will jumpstart themselves with a GLP-1 and, have a epiphany. And they'll be like, oh my God, I've lost so much weight. I'm exercising now. I feel fantastic. I am never going back. I don't care what I do. But that's an epiphany, and it happens to people. So it's a real thing. And the GLP-1s are great that way. But you stop them, almost everybody's going to regain that weight. But it's not everyone, but almost everyone. So that's why. It's just like reversing a bariatric surgery.
I kind of tell my patients you're still the same person on the inside. The medication works while you're taking the medication, but once we come off the medication, you're still that same person with that same metabolism. And if you start increasing your calorie intake back to where it was pre-treatment, your weight will come right back on and you'll get right back where you were again. And that goes for surgery, it goes for medication. So that's the take-home message. This is a lifelong therapy, no matter which therapy you choose, and it has to be continued lifelong.
Thank you for that. One last question, and I think this is how I'm interpreting it. Is there any age restrictions?
Well, there's a pediatric indication. So historically, we've done weight loss surgery on people as young as 13 or 14. Those are now relegated to pediatric surgery centers. And my oldest patient was 83. So I think it depends on the individual. I see some 60-year-olds that look like they're 100, and I see some 80-year-olds look like they're 60. So everyone's an individual, and we can certainly evaluate the individual when they come in for the office. And I ask my patients who are in their 60s and 70s, if your doctor said you need your knee replaced, what would you say? You go through it in a minute. This is no different. This is a way to make yourself live longer with a better quality of life. So I think it's a matter of looking at the individual, looking at your medical problems, looking at your biologic age, and seeing where we fall.
Perfect. Thank you so much. Dr. Kane, is there anything further on the slide that you wanted to address, or?
Again, this was put up again. Dr. Gusky put this up in the very beginning. It was put up again so people could really sort of get an idea. I don't know if you can see my cursor here, of the newer medications. The cursor is a little slow, but the newer medications here that are used, all the GLP-1s, and they're very effective. And how effective they are at 16% and 20% excess body weight, it more effective really than a lot of the technically non-operative endoscopic procedures, which are in the middle here. So times people don't know what an ESG is. These are endoscopic procedures done on the stomach. Again, almost similar to the band. The lap band was in here, as you can see. Gives you generally a 25% weight loss, but Zepbound is, right there with them. It's the other operations, the ones that are more commonly done, do have a significant greater weight loss profile and are significantly more durable. So again, a lot of it is combination treatments. If you're carrying too much weight, there is something that can be done for you. So nowadays, there are things. You do not have to be relegated to, hey, nothing can be done, just live with it. That is not true. It's not the easy way out. You're not Chicken Little if you're trying to do this. It has to be taken seriously. It's a hard thing to go through, but it will be effective. You will get results out of these.
Okay, thank you again, Dr. Gusky and Dr. Kane, for taking the time to answer questions and for sharing such valuable information. But we are here to support you through every stage of your health journey, including your weight loss goals. So for additional information about our behavioral health hospital and therapy scheduling options, you can scan the QR code on the screen. And then on behalf of Ascension, Illinois and St. Alexis, I want to thank everyone who joined us for this evening. We truly appreciate you taking the time to learn more about our weight loss options. And a very, very special thank you again to Dr. Paul Gusky and Dr. James Kane for sharing their expertise and dedication to their patient care. If you do have any questions about what options, go ahead. Did you want to say something
I
next?
just wanted to thank Cindy and Kristen and do that valuable help with our technical aspects here.
Thank you.
Thanks, guys.
Thank you. And if anyone has any questions about what options are right for you, you can call 855-692-6482 or use the QR code.
Thanks, guys.
Thank you.
Have a good night.
You too. Bye-bye.